And my dear students, I welcome you all to another session of RESA DNB online academic activities. Today we have 4 theory questions to be answered. First, I hand over the session to professors. So wasting much of your time. First topic will be presented by Dr. Archana Lal. Over to professors and Dr. Archana Lal.
Good evening, sir.
Good evening. Dr. Archana, if you are ready, you can go ahead.
Yes, sir. Today my topic is anesthesia for live donor liver transplant. So liver transplantation, it is a well-accepted treatment modality of many end-stage liver diseases. The main issue in liver transplantation is the shortage of deceased donors to accommodate the needs of patients waiting for such transplants. Live donors have tremendously increased the pool of available liver grafts, especially in countries where deceased donors are not common. Western countries tend to perform more deceased donor liver transplants, whereas in Asia, live donor liver transplant or LDLT is more common. The main ethical concern of this procedure is the safety of the healthy donors who undergo a major abdominal surgery, not for their own health, but to help cure others. So, coming to a live liver donor. So, the liver, it's an organ that can, within a few weeks or months, regenerate to its original volume. Large part of its tissue, up to 70%, has been surgically removed. The 30% of the remnant liver remains sufficiently functional to meet the metabolic needs of the donors. Therefore, a healthy person can donate part of his or her liver for liver transplant. A live donor liver transplantation, it started with pediatric liver transplantation, whereas they were using the left lateral segment and has gradually undergone an evolution to adult right lobe liver transplant. Usually nowadays, a right hepatectomy is performed on the donor as the left lobe of the liver lobe is not sufficient to sustain most adult liver recipients. Coming to the beneficial aspects of live donor liver transplant, there are many advantages in live donor liver transplant when compared with deceased donor liver transplant. Firstly, live donor, it shortens the waiting period for recipients to receive the donor graft. Secondly, it being an elective surgery, whereas in deceased donor liver transplant, the procedure often takes place outside of routine hours. So the team members, they may be tired from their daily work and the staffing levels may be low and usually with less personnel as compared with those in routine practice. The surgeons and anesthesiologists caring for the liver transplant recipients must prepare themselves to perform and manage a complex and prolonged surgery in patients who may have unstable hemodynamics owing to massive blood loss from profound coagulopathy, hypothermia, complex metabolic and electrolyte disturbances, and nature of the surgical procedure, such as sudden decrease in venous return and cardiac output by clamping of the inferior vena cava with or without veno-venous bypass. So it is a very challenging work both physically and mentally for all the participants. By contrast, in live donor liver transplant, it usually starts in the normal working hours and all members of the transplant team are in a good condition with high staffing level to start their daily clinical tasks. Furthermore, the recipients are usually well prepared and are in a good medical shape in that they have been optimally improved preoperatively by surgeons, anesthesiologists, hepatologists, cardiologists, and other specialists of the liver transplant team. Once a suitable donor is available, live donor liver transplantation can be performed, thus shortening the waiting period and eliminating potential death among the patients in the waiting list. The quality of the liver graft is good as it is procured from a healthy donor with stable hemodynamics without needing any inotropic drugs for support during the organ procurement, and it has very short cold ischemic time, thereby minimizing preservation injury. Likewise, live donor liver transplant recipients are usually less sick and in better condition in comparison with deceased liver transplantation recipients. Therefore, the outcome is similar to or even better than that of deceased liver transplant recipients in terms of graft and patient survival. Next one is about donor selection. The biggest ethical concern arising from live donor liver transplant is the safety of the donors who undergo major abdominal surgeries not for their health or benefit, but risk themselves with a variable rate of perioperative morbidity and even mortality. The donor selection criteria may vary in different centers, but all have the same principles to minimize the risk to the donor and maximize the benefit to the recipient. The evaluation process is performed stepwise in 3 to 4 steps, aiming to ensure that the potential donor is healthy enough for this procedure and to identify and rule out the potential donor from any unsuitable condition such as too complicated or abnormal liver, vascular, biliary anatomy, and small liver volume that may increase the risk of complications to the donor. Failure or delay in identification of any unsuitable conditions may lead to intraoperative abandonment of the procurement procedure. So, the potential liver donor is usually a close relative of the recipient who must abide if there is any with local regulations on live organ donation. The donor should be a healthy adult younger than 60 years who is competent and willing to donate part of his or her liver without any exertion. The complete pre-operative evaluation includes medical, physical, laboratory, psychosocial, and imaging assessments by non-invasive computer tomography, CT volumetry, multiple detected three-dimensional CT angiography, 48 three-dimensional magnetic resonance cholangiography, and abdominal echo to identify and confirm that the liver is anatomically suitable to be donated and to ensure donor safety. Informed consent for donation should be obtained from the donor after explanation of the donor risk. A potential donor should be excluded if the individual is a carrier of hepatitis B or is infected with hepatitis C and HIV virus. However, donors who are hepatitis B core antibody positive are considered acceptable because of the high prevalence of hepatitis B infection in Asian countries. Perioperative active immunization and prophylaxis with lamivudine is given to the recipient who will receive the hepatitis B core antibody positive graft. This may prevent de novo hepatitis B virus infection after donor liver transplant. A blood group that was identical or compatible was required in the past, but now a donor who is ABO incompatible is acceptable when there is no other suitable potential donor is available. Operations in donors with abnormal liver function, moderate fatty liver, and infection with fever should be postponed until normalization of laboratory data and improvement of the degree of fatty liver have been attained. Next, coming to the anesthetic management in live donor liver transplantation. For pre-operative management, we should get complete medical history, physical examination, preliminary laboratory, serologic test, and radiological examination should be performed and carefully evaluated by the anesthesiologist prior to the operation. Diabetes mellitus or hypertension with regular control is accepted for live donors. The donor would be informed of the risk of general anesthesia and the risk associated with the use of invasive monitoring devices. The donor would also be advised on autologous blood donation. The options of post-operative analgesia would also be discussed and would include either thoracic epidural analgesia or patient-controlled analgesia using an intravenous opioid such as morphine. Epidural analgesia, if placed appropriately, has been shown to achieve good analgesia in patients undergoing major abdominal surgery. However, its use in liver resection is controversial as postoperatively patients may suffer postoperative coagulation derangement, putting the patient at risk of developing an epidural hematoma. But this complication is extremely rare. Patient-controlled analgesia using intravenous morphine is also not a safe option. Altered liver function could increase the risk of toxicity with systemic opiates, resulting in increased sedation and potential respiratory depression. Coming to the intraoperative management, the anesthetic technique of choice is general anesthesia with tracheal intubation and controlled ventilation of the lungs. It may be used with or without addition of epidural analgesia. Besides standard monitoring, the donor would require temperature monitoring, continuous intra-arterial blood pressure monitoring, and central venous pressure monitoring. One or two good-sized intravenous peripheral catheters should be inserted for rapid fluid infusion in the event of rapid blood loss. A centrally placed large bore intravenous catheter may have to be considered if the donor has poor peripheral venous access. General anesthesia can be maintained with inhalational agents or with balanced anesthesia or either with total intravenous anesthesia. As a sizable part of the liver is removed, the anesthetic drugs used should have minimal impact on liver blood flow and post-operative liver function. Halothane should be avoided because of its hepatotoxic effects. Isoflurane and desflurane are not hepatotoxic and produce negligible hepatotoxic metabolites. Isoflurane has traditionally been favored for liver dissections due to its preservation of regional blood flow. However, the aim of extubating the donor immediately post-operatively appears to favor the use of desflurane maintenance of anesthesia with propofol as the induction agent because of their pharmacokinetic profile. Desflurane appears to have no long-term impact on hepatic or renal function. The use of the benzyl isoquinolone group of muscle relaxants like atracurium or cis-atracurium may be favored over rocuronium or vecuronium for muscle paralysis, as they have no organ-dependent metabolism and do not have any hepatotoxic metabolites. Live donor hepatectomy is unlike ordinary disease total hepatectomy in that the inferior vena cava should be preserved for the live donor. It is also different from the ordinary liver resection. There, the live donor partial hepatectomy with preservation of graft viability and adequacy in terms of liver volume and function for both the recipient and the donor is of principal importance. Live donor hepatectomy is therefore performed without control of the hepatic inflow, such as a Pringle maneuver. So, what is Pringle maneuver? The Pringle maneuver, it consists in clamping the hepatoduodenal ligament. This interrupts the flow of blood through the hepatic artery and the portal vein, which helps to control bleeding from the liver. The common bile duct is also temporarily closed during this procedure to protect the graft and remnant liver from ischemic injury. So liver resection without Pringle maneuver may be associated with difficulty in control of bleeding during parenchyma transection. As a result, this will produce blood loss, thus requiring blood transfusion, which may increase postoperative morbidity and mortality. The option of preoperative autologous blood donation is given to the donor in some centers to prevent transmission of infectious diseases and immunomodulation induced by allogenic transfusion. Intraoperative blood loss was found to be an independent risk factor for donor complications. Therefore, blood loss should be minimized to prevent complications in donors. Intraoperative blood loss can be minimized if liver parenchymal transection is carried out with strict adherence to a meticulous surgical technique. The anesthesiologist can help minimize blood loss by lowering the CVP. There, the venous pressure of the hepatic vein and hepatic sinusoids is equal to the pressure of the CVP. Indeed, intraoperative low CVP resulted in significantly less blood loss during liver resection. Parenchymal transection under CVP of less than 5 mm mercury has indeed resulted in less blood loss and allows easier control of inadvertent venous injury. Fluid restriction, forced diuresis, epidural analgesia, vasodilators such as morphine, nitroglycerin, normovolemic hemodilution, and non-normovolemic for phlebotomy after induction of the anesthesia are all means to lower the CVP effectively. Autologous blood donation before the operation can prevent homologous blood transfusion and its immunological side effects. However, an autologous blood donation 2 days before the operation did not affect the CVP level during hepatectomy, but was effective in lowering CVP when phlebotomy was performed during liver transplant. Nowadays, donor hepatectomy can be done with minimal blood loss. Although a CVP of 5 mm mercury is recommended, a too low CVP, it bears a potential risk of air embolism during the division of the liver. Maintaining normothermia is also crucial in helping to preserve an intact coagulation system. This can be done by infusing warm fluids, employment of patient warming devices, and using warm fluids for lavage of the abdominal cavity. After procurement of the liver graft, the cumulative fluid deficits resulting from fluid restriction should be replaced in the donor to prevent acute renal injury. Most donors can be immediately extubated in the operating room and are sent to the intensive care unit for post-operative care for safety reasons. Next is the post-operative management. As said before, most donors are extubated immediately post-operatively unless the surgery has been very long, the patient had received a massive blood transfusion, or there had been protracted intraoperative hemodynamic instability. They are monitored closely for post-operative bleeding in the first few post-operative days. Other early complications include transient hepatic dysfunction, portal vein thrombosis, deep vein thrombosis, and pulmonary embolism. Major morbidity and especially mortality in a healthy donor is a devastating event. Intravenous patient controlled analgesia and epidural analgesia can both be performed satisfactorily in a liver donor. It seems that pain relief is better provided by the epidural analgesia in the donor. Typically, the epidural catheter is kept for 3 to 5 days, as this would be the time required for the coagulation profile to return towards normal. Based on American Society of Regional Anesthesia guidelines, the epidural catheter should be removed when international normalized ratio or INR it is either equal or less than 1.42. However, the use of INR as an indicator of coagulation defect does not concur with the results from thromboelastograph. Thromboelastograph monitoring would be advantageous over INR to minimize unnecessary transfusion of fresh frozen plasma prior to removal of the epidural catheter. Next is an addition of ABO incompatibility. Actually, an ABO incompatible blood transfusion is a medical hazard. It usually results in severe immune reaction and acute hemolytic transfusion reaction causing shock, kidney failure, circulatory collapse, and death. In the transplantation setting, ABO incompatibility was contraindicated in the past because it may result in antibody-mediated rejection with high morbidity and graft failure. Today, however, it can be done with immune modulation and is well accepted in emergent live donor liver transplant when no ABO compatible donor is available. Measurement to reduce the antibodies against the donor ABO is the key to success in organ transplantation. Perioperative plasmapheresis and the combined use of multiple immunosuppression with or without splenectomy were measures used in ABO incompatible living donors for kidney and liver transplantation. For anesthesiologists, care should be taken during blood transfusion because the red blood cells contains the antigens of own group and the plasma contains antibodies against all blood type groups except own blood type. Therefore, when blood transfusion is required, leukocyte poor red blood cell or irradiated red blood cell from a person whose blood type is identical to that of the recipient should be given. However, when FFP or platelet is required, the AB group type FFP and platelet, which contains no antibodies against the ABO system, should be given regardless of which blood group the recipient belonged to. The anesthesia management regarding blood transfusion is practically similar. Identical red blood cells with a similar blood type to that of the recipient and AB, RH negative FFP and platelet should be used. So that is regarding anesthesia for live donor liver transplant.
Very well done for a CME talk. Your entire presentation is an excellent preparation if you are being given this topic to talk in a CME program or in a conference.
Okay.
Our aim is to mainly prepare the students for writing the answers in the examination to get through your theory examination. Don't think I am discouraging you. When this question is asked, discuss the anesthetic management of a live donor liver transplantation. You have prepared only for the donor side. What about the recipient?
It was only for donor actually.
No. The whole question is live donor liver transplantation. That means we are not only doing the hepatectomy in the donor, it has to be transplanted into the recipient also. That is why when you sent the write-up, I did not send you any clue that you have to include the recipient management also in this, isn't it? Whenever a question is asked, what is the difference between a deceased donor kidney transplantation and a live donor liver transplantation? We always say deceased donor kidney transplantation is a quasi-emergency. That is, you do not know when the organ will arrive, but you will get a notice that so-and-so is willing to donate and there is likely to be a harvest of organs from the deceased donor. And if you have any suitable recipient in your hospital, please keep them ready because your turn is to take the organ. And you may have to prepare the recipient in a hurry and then perform the whole procedure. So we have to discuss both about the organ retrieval in the brain dead donor as well as the management of the anesthesia in the recipient also. Similar to that, when you talk about live donor liver transplantation, if it is said live donor liver donation anesthesia, you are absolutely right in stopping with this preparation. But the question is, it is live donor liver transplantation. So, whatever initial description you have given about what are the advantages of a live donor program and the complications or the disadvantages included, everything is very good for knowledge sake to be disseminated to all the students. But in the examination point of view, that entire thing can be condensed into 3 sentences. One is live donor liver transplantation is an elective procedure. We can do it at our place and time of convenience. Okay, so as you rightly said, we have a healthy donor who has been investigated in detail and found to be fit, willing to donate, mentally prepared, and with all the pre-op preparations of adequate blood storage, pre-operative investigations, we take up the donor and do the surgery. Simultaneously, the recipient is also operated, and once the organ is retrieved, it is flushed with a preservative solution and immediately transferred and then anastomosed into the recipient body, isn't it?
Yes.
So that program is inclusive of the recipient anesthesia also. And whatever you have told about the liver donation program, the live donor is all completely right, except what you can add to that is what is the position of the recipient, I mean the donor, and what are all how the incisions are made. For if it is a right donor, right hepatectomy, what is the incision? If it is a left hepatectomy, what is the incision? And what is the bearing of that to our anesthesia? And which hand will be kept close to the body, which hand will be abducted, or both the hands will be adducted and kept close to the body. That also plays an important role. And once you complete the donor anesthesia, you have to include the challenges in the recipient anesthesia also. So what are all the challenges in the recipient anesthesia? Any idea?
At least must tell the phases of the recipient.
Actually, there are 2 phases for liver transplant operation. One is the pre and hepatic phase, and the other one is the anhepatic phase. So the pre and hepatic phase
and after that,
Neohepatic
phase,
also.
and after that,
neohepatic phase.
yes.
So three phases are there: pre-anhepatic, anhepatic, and neohepatic. Because neohepatic also carries the risk of reperfusion injury. Okay.
Yes.
So that also has to be discussed, and so that is why it is a very lengthy question. So if you want to write it in your theory examination, you will find it very difficult to condense it and write it within that 20-25 minutes time you have. So you must try to concise and then present as much as possible, and there is no need to quote any statistics or the studies or the references in this sort of theory answer paper when you write. That's why I told you this is an excellent preparation for a CME talk or a conference presentation. Okay, but when it comes to the writing your theory examination, you must always keep in mind that whatever answer you are preparing, you should be able to complete it within the stipulated time that is available for you in writing your theory exam. Okay, so with that, you can say these are all the extra points that are added just for spreading the knowledge, but mostly you must try to curtail it to the maximum possible, keeping the time element in mind. That is very, very important. Otherwise,
actually, they need not write sentences. What she has
that's what you have been repeatedly
copied
saying.
it from the text. You don't have to say it from the text straight away. You must understand what you have read and try to write that. That is a way you can write in a concise manner. And like Sir said, you can finish within the stipulated time. So don't take it from the text. All that you have been saying is, as if you're reading straight from the textbook or from the journal or something like that. That's not what what we are expecting from you. What we're expecting from you is to read the topic, understand the topic, and write by yourself. Right? Don't keep looking at the book to write whatever you want to write. Understand the question, take down the answers in your mind and write it down. That way you will do much, much better. Okay, so this way you will not remember what you read or wrote. So please understand what you are reading. That's what is important. Okay, Archana.
Okay.
All right. Yeah.
So shall we go for sharing the PPT on that?
Yes, sir.